approaches of pharmacology and behavioral therapies have been used in the past to treat addiction, and there are multiple variables that do play a role in the difficulty to achieve recovery, but it is possible. Some of the setbacks are due to limited access to methadone clinics, diminishing state budget for the mental health and substance abuse treatments, and there's just simply not enough education on where to even seek help to begin with. The pharmacotherapy is controversial in the rehabilitation field due to the fact that some of the medications used in the treatments do offer similar properties to opiates, such as methadone. And according to research, I mean, there are just as many people that support the use of methadone as there are that are against it. And it has been the standard choice in heroin abuse treatment over the years, and has been the most researched. Methadone is a synthetic version of heroin, which has raised concerns that methadone is treating one drug addiction with the use of another drug. What it does is it blocks the euphoric and sedating effects that a person using heroin and other opiates would experience. The use of methadone is said to relieve the craving and the withdrawal symptoms that are common with the heroin addiction. But when used appropriately, this is effective, and it is a safe treatment for opiate addiction. I apologize. This treatment method is also favored because of the low cost and the ability to keep users in treatment for a longer period of time. In order for an addict to obtain methadone and to continue this method of therapy, they must agree to federally regulated periodic random drug screenings. So many argue that methadone is not always used as intended, which is why there are mandatory stipulations that they must obey that come with the methadone therapy. There is also buprenorphine. Sorry, I cannot pronounce that correctly. It is also medication-assisted recovery medication, also known as Suboxone. It is a highly affinitive partial opiate receptor antagonist that has a long duration of action. Back in 2001, as a result of the Narcotic Addiction Treatment Act, an exemption to the restriction that methadone was placed was altered, and Suboxone was approved for the opiate addiction treatment. This is a prescribed medication that is approved by the Food and Drug Administration for the treatment of opiate dependence. The intended use is to be administered while a person is in moderate withdrawal. Naloxone is a narcotic antagonist that is added to this to prevent abuse or possible misuse of this medication. And of course, there's always detox or detoxification. This is typically the first step in any treatment process when it comes to heroin addiction, and it can be the more challenging to treat than any other drug dependence in respect to the physical addiction to heroin and the withdrawal symptoms that are associated with it. Detox is ultimately to initiate abstinence while reducing the symptoms of withdrawal. Now, medical management by a facility with trained personnel in heroin withdrawal is crucial when dealing with the seriousness with these withdrawal symptoms in programs such as the Suboxone and methadone. They are not a step-down program. Medical management personnel that may include, they may have to treat dehydration, balance electrolytes, administer vitamins and other nutritions, and just monitor the patients for possible complications that could happen. The withdrawal symptoms are the most severe within the first 48 to 72 hours after their last opiate use and will dissipate over the next 7 to 10 days. However, feelings of anxiety and restlessness and cravings, they can last for an extended period of time. As far as education and prevention is concerned, in the last 45 years in particular, young people's exposure to illicit drugs has increased dramatically, as we're currently seeing around our nation. Despite more information about drugs, the knowledge still, or so it seems, remains limited. Also, social pressures remain to be the first reason for taking drugs, and education initiatives just cannot, be effective alone. The prevention of drug-related problems is widely seen as an educational issue. Prevention and education, however, they are not the same thing. While similar, they do have different meanings. intervention in the context of illicit drug use is in the intention or desired outcome of the intervention. There are 3 levels of prevention. There is primary prevention, which is usually seen as preventing young people from starting to use drugs. The secondary prevention refers to the minimization of drug-related harm among those who use drugs and can be defined as including efforts to encourage those who have started to use drugs to stop doing so in different ways on how to do that. Tertiary prevention could be defined as treatment and rehabilitation of those with dependency problems. In order to help young people better understand what risky behavior is, there is a need to help young people develop an understanding of the nature and risk of as opposed to danger. There are certain types of drug education, such as DARE, they don't effectively prepare young people for the reality of drugs and offer other situations. It's simply more of a scare tactic. There is, unlike prevention, education is not an intention or outcome. Education is the process of teaching and learning, including interaction between the educator and the individual or the group. Education is the process of communication where the goal is essentially to prevent or enrich unhealthy states and or enhance better well-being. Effective health education will produce changes in knowledge and understanding, or simply different ways of thinking to influence values, beliefs, or attitudes, and facilitate acquisition of skills and change behaviors and lifestyles. But to be effective in health and drug education, it requires the individual to receive and understand and hopefully act on the information that is communicated to them, depending on age and so forth. Teaching methods that are solely based on the prescriptive instruction are less likely to be effective, primarily when the target may be resistant to the message, regardless of age. And on the other hand, effective learning is more likely to be the result of the teaching methods that facilitated interaction with the content of drug education programs, as well as relating ideas to existing knowledge and real-life experiences. All substance abuse methods require commitment from schools and home, even starts at home. Excuse me. Even school nurses are now supplied with Narcan in their nurses' offices. Should desperate measures come into play and should they see an overdose occur on school property, they will be have the proper remedies on hand there that can hopefully help the person in jeopardy. The objects to better satisfactory trainings and education in school are to help identify specific objects for drug education. And the overall outcome of those objectives would be to obviously increase one's knowledge regarding drugs and alcohol, to promote good citizenship through different participation and contribution to school policies and improve decision-making skills, and also build relationships with students so they are comfortable opening up to their peers and to their school personnel. And like anything, education must be kingpin, because early education begins at home, and it's important that parents have the correct tools to share with their children when engaging in these difficult topics of conversation. It's obvious that sometimes parents don't know where to begin with said topics, but parents have always been viewed by society as occupying the central role in their children's education, which is true, but as of late, school and home have been considered two separate spheres. There have been surveys conducted where through focus groups included with suburban parents in order to gauge their feelings and preparedness for conversations regarding substance use with their children. And according to the survey, there were multiple knowledge deficits, such as what kind of drugs will their children encounter. They felt they didn't know which drugs that may be coming in and out of their area per se, what the consequences are of specific drug use. Also, parents expressed concern in regards to the knowledge gap with their own lack of experience in drug use. There was also some concern about what age is the appropriate age to begin having these conversations about drugs, and knowing what types of information to present to the children depending on the age. And talking to your children, about these tough topics is always difficult and awkward. So it's just imperative to be honest about one's feelings towards the drugs, both positive and negative, when talking to your children. And it's important to create a balance between educating and making them aware that drugs are a serious threat. And some of the ways to come about those knowledge deficits is, you could research together. If you're uneducated on the drugs, drugs, alcohol, how they're used, the effects, you can research together, and that way you're both learning, and that communication is already there, and that bond is already built. During these studies, there were also participants that have or have had previous drug use. The participants were asked where they felt drug education had failed them. Some participants felt that drug education was not realistic or relative to their needs or experiences, and some believed their previous education was focused heavily on alcohol and marijuana and not enough of the other drugs. School districts have begun to implement different programs to educate both parents and students in some of the dangers of drug abuse. Programs I know which our school district does is such as a Drug 101 program, where they have the parents in a separate room and the children in a separate room, and they go over the different things, where they go over the current drug trends, the consequences of drug use, local drug availability. For the parents, they go over some of the places your children may be hiding the drugs in their rooms, or actions that they might have if they are on drugs. To teach different techniques of how to talk to your children, and how to start a conversation, drug slang. You get to see what the different substances look like, so you're aware of what you're looking for if you do see odd behavior. And also teaching your children how to refuse drugs from peers is important, and what to do if they do get into those sticky situations, and the warning signs of drug use. Currently, the government has a vague strategy in place for basically the next decade to educate, beginning in the primary schools, as a basis for later interventions involving a range of inputs, including youth work, peer education, and community-wide approaches. And those strategies are intended to support activities such as how to teach the young people from a young age, 5 and up, the skills needed to resist pressures of drug misuse, including an integrated approach to personal, social, and health education in schools. They want to promote healthy lifestyles and positive activities that don't involve drugs, and also to ensure that gender, ethnicity, and culture are not barriers when it comes to access to the appropriate programs, and identify what practice works best for them in their lifestyle. And the emphasis behind any drug education policy and practice has significant implications for policymakers and practitioners in school, and also law enforcement. And it's imperative to just identify the best practice and act accordingly. And in the past, it has been apparent that past drug education efforts have failed due to the scare tactics, the fear, or reasoning by providing the information alone has not been enough. And with this terrifying, horrific heroin epidemic at an all-time high, when educating children on drugs in schools, it needs to be a more forward approach, and open and honest. And yes, you want to scare them, but you want them to know the realities of what can happen.